Yes. I'm struggling. There's something, I don't know whether someone can help me. There is I can't stop this video simply because the button is below the there's something, I don't know whether someone can help me. There's I can't stop this video simply because the button is below the Okay, I'll try again. We try to see the video. I don't know whether it's going to work. Okay.
Dear colleagues and friends, today I will speak about COVID-19 pandemic and the influence of the pandemic on mental health and suicide. But first, as you know, I am association, and my mother institution is Karolinska Institute, where suicide prevention and prevention of mental illness. I am also the director for the and training in suicide prevention and head for the national Swedish unit and regional Stockholm unit for suicide prevention. What is happening in mental health due to the COVID-19 pandemic? We know that we have more than 600 million confirmed cases, maybe even more, and more than 6 million deaths due to the COVID. So it was a horrible blow on our global population due to the socio-economic implications, but also due to the mental health impact on anxiety, stress, sleep problems, sadness, helplessness, depression, post-traumatic stress disorders, and suicidal thoughts and behaviors. And especially vulnerable groups, elderly, healthcare workers, caregivers, females, and adolescents hit by this pandemic. Searching for the terms COVID-19 pandemic and mental health on PubMed, there are more than 18,000 results, many observational studies, which have less scientific value, but are very important from the clinical point of view. We have also quite many randomized controlled trials and many systematic review and meta-analysis. Most investigated outcomes were depression, anxiety, stress, and sleep problems in general population, among healthcare workers, patients with COVID, children and adolescents, elderly people, and caregivers. A systematic review published in The Lancet in 2021 on global prevalence and burden of depression and anxiety disorders in 204 countries and territories showed increased prevalence of major depressive disorder and anxiety disorders, especially among females and younger adults. It was calculated that additional 33 million cases of major depressive disorder and 76 millions of cases of anxiety disorders globally were added to the burden of disease by depression and anxiety. World Health Organization performed an umbrella review of systematic reviews and meta-analysis, and they could see similar results that global prevalence of anxiety and depression increased by 25%, and main risk factors for worse mental health outcomes was younger age, female gender, and pre-existing health conditions. When we look at the map, global map, we can see that global prevalence and burden of depression and anxiety during COVID-19 pandemic was unequally distributed, partly to the facts that the COVID-19 was not evenly distributed on the globe, but also due to the registration systems we have in different countries. So you can see that percentage change in prevalence in those very dark red places in burgundy color were over 38% in some of the countries on different continents. When we look at the investigations concerning healthcare workers, we could see that healthcare workers who were exposed to COVID-19 pandemic with mean age of 36 years in those almost 240 published articles until March 1st, 2021, 42% had sleep problems, 42% had anxiety symptoms, 40% had acute stress, 33% depressive symptoms, 32% post-traumatic symptoms, 37% felt that they were burned out. And the prevalence of mental health symptoms was higher and is higher among healthcare workers compared with the general population. And of course, the worsening in the mental health of healthcare workers progressed as pandemic dragged on, which of course calls for special activities concerning prevention. The literature also shows what happened in emergency departments. And when we look in change in suicide-related emergency departments visits compared to the same period in previous years for adults, we can see that they are very non-conclusive results. In some parts, there was less appearances to emergency departments. People were probably afraid to come and to contract COVID in the hospitals. And in few places, like in Japan or in Lombardy and Lazio region of Italy, there was increased emergency department. There were increased emergency department visits. What COVID-19 impact is on youth mental health? Of course, young people have similar symptoms, increased anxiety, depression, but also fatigue and distress, and especially in older adolescents, especially in girls, and in children and adolescents living with neurodiversities and chronic physical conditions. Risk factors for those young adolescents and young adults were living in rural areas, having low family socioeconomic status, being a family member or friend to a healthcare worker. Of course, healthcare workers had no time maybe to pay the same attention to the household and children in that household. Increased social media use was also a risk factor, and school closure. But the protective factors, on the opposite, was social media use included good communication with peers and including positive and cheering up activities online, social and family support, positive coping styles, access to entertainment, physical exercise were other protective factors for those young people. And the results for suicide-related emergency department visits were similar as for adults, non-conclusive. For example, from France and Paris, we can see both decrease during the first lockdown period and later on 100% or 200% increase of visits to emergency departments. We have also similar results for California. What happens with suicides and during the COVID-19 pandemic? First, some basic epidemiological facts. Around 700,000 suicide deaths worldwide is estimated to occur annually. And global suicide rates were decreasing since the year 2000. However, suicide is still a prominent leading cause of death for young people and adolescents between ages 15 to 29 years of age. For each suicide, approximately 20 persons attempt suicide. And the global age standardized suicide rate is 9 per 100,000 for the total number. For males, it's higher, almost 13 per 100,000, and for females, lower, 5 per 100,000. But it varies between different continents. So, for example, if you look at Africa continent, males are very high suicide rates, and also in Europe. But when you look, for example, in Southeast Asia or Western Pacific, the differences between females and both sexes are not so big, but the males are prominent on each WHO, in each WHO region. As I mentioned before, suicide is the fourth leading cause of death in young people, 15 to 19, and also 15 to 29 age. And among females is the third leading cause of death, and among males, the fourth leading cause of death after traffic accidents and different kinds of injuries. Risk factors for suicide we can characterize as modifiable factors, which means those who have psychiatric disorders, social isolation, poor lifestyles, poor coping strategies, are unemployed with financial difficulties, poor housing, with poor family and relations, many conflicts, school dropout, access to lethal means of suicide, have risk factors which we can modify to treatment and preventive strategies. But what happens during the COVID-19 pandemic? We can see that in most investigated outcomes were suicide rates and self-reported suicidal thoughts and behaviors. And in a paper published in 2021 in the Lancet Psychiatry by the consortium, big international consortium, we can see that in 21 high and upper middle income countries, suicide numbers have remained largely unchanged or declined in the early months of the pandemic compared with the expected levels based on the pre-pandemic period. These results were followed up for more months, for a longer follow-up period, and the results were the same. However, there are some country-specific or even within the same country, region-specific differences. So the suicide rates did not decrease in Hungary. In opposite, in relation to the previous results, they increase in all age groups. In Spain, we have the highest suicide rates for all ages in the country's history. And suicide rates increased in adolescents as well as in France, and especially during the period when children came back after closures of schools, when they came back to schools and maybe were targets for similar risk behaviors with bullying, etc., as before. In Poland and Japan, there was increase in females. In India, increase in males. In Brazil, increase in elderly and in poorer regions. In United States, increase in Hispanic males, Afro-African individuals, and Asian and Pacific Islanders. But the general picture was that there was not increase during the COVID-19 pandemic. And the question is why? Of course, we all know that there were massive economical stimuli from governments in almost all countries. They were regional stimuli in healthcare systems and concerning housing situation. Also, individuals received paychecks in some countries. We know also that there was increased use of digital services in treatment and prevention, as well as in communication with significant others. There are reports and papers showing that during COVID-19 pandemic, use of alcohol and drugs diminished in many countries, that family were more cohesive and did more positive activities together. We know also that increased awareness of healthy lifestyles and compliance to them increased. For example, physical activities, even in very small stages, WHO had many advices what to do and how to cope with that. Dietary habits, sleep advices, and advice about other health behaviors were massive, and probably people were complying to those advices. We know that the prevention and treatment of suicidal behavior can be performed from the public health approaches perspective or healthcare perspective. And now I will go through very quickly through those evidence-based approaches. When we look at the pharmacological treatment, we know that antidepressants, lithium, and antipsychotics are very potent preventive medicines in suicide prevention. But we know also that pharmacoepidemiological studies show more positive results in comparison with single randomized controlled trials, mainly due that much larger samples are involved and we have a longer follow-up periods and also maybe less stringent participant exclusion criteria. When treating suicidal people with antidepressants, we must be aware that during the first period of treatment, there is increased anxiety and suicidal urges. Therefore, we need to combine antidepressants with psychotherapy, but also in some cases with anxiolytics, and have a very active follow-up of treatment and possible side effects. Ketamine, there are studies now showing rapid decrease of suicidal ideation, but we need, of course, more studies to look at long-term effects, safety, etc. Lithium, as I mentioned, is a very potent anti-suicidal medication when compared to an active control and when compared to placebo or non-specific interventions. The same is for clozapine, which decreases suicide risk in psychotic disorders. Concerning psychotherapy, there is a good and massive evidence concerning cognitive behavioral therapy. We have, of course, many more studies with cognitive behavioral therapy than other therapies. However, we know that also other therapies like dialectical behavioral therapy, but also family therapy, and some interrelational therapies are very good in decreasing suicidal ideation, suicide behavior, and repetition of self-harm. We know also that crisis response, safety planning is extremely important to put attention to warning signs, to strengthen coping strategies, and to strengthen sources of support. Barbara Stanley, with her colleagues, did a review of safety planning of different interventions, and now those interventions concerning safety planning are included in clinical guidelines in many countries for suicide prevention. Continuity of care is extremely important. We know that usually a person who is treated for a suicide attempt in the hospital has many contacts before treatment is provided. And during those contacts, they drop out from the treatment. Many years ago, World Health Organization performed a randomized controlled trial of effectiveness of brief intervention and contact for suicide attempters in comparison with treatment as usual, and put attention to that those follow-up contacts were extended for quite long period of time, more often during first weeks, 11 to 12 weeks, than once per month, but then they were conducted by students or volunteers, by phone calls or visits, up to 18 months follow-up. And the results published in the WHO Bulletin were amazing. Suicide was diminished significantly from 2.2% on the population who was studied to 0.2%, 10-fold. And also, death by other causes of death was diminished. Then we now, with the World Health Organization and my mother institute, Karolinska Institute, we have performed a project on different continents. We try to repeat the similar intervention in North America and United States on veteran populations, in Latin America, in Brazil and Uruguay, in Europe, in Sweden, in Asia, in India, in Africa, in South Africa. Coming back to COVID-19 pandemic, we know that digital interventions developed immensely. And there are pros and cons for that. Pros are that patients, psychiatric patients, can often be treated on digital means. There is a reduced cost, so I know that many countries are trying to put in the national healthcare systems now more digital visits to the follow-up. It is, of course, cheaper for patients not to need to travel to the hospitals, and also for relatives who need to follow patients. And there is maybe even reduced stigma and discrimination, because if the patient and the family has possibility to communicate with the psychiatrist, psychologist, or social worker in a room where they are not seen by others, it can be felt more positively for other people. But the cons are that we have lack of infrastructures, the access to the internet, electronic devices, and integration within the healthcare system is still poor in some parts of the world. And of course, there is a lack of technological capabilities for older people or people with serious mental illnesses or in early stages of dementia. From the public health perspective, I will shortly only mention that restriction of access to lethal means like firearms, pesticides, hotspots and jumping sites, railways and subways, medication, and hanging possibilities and ligature points in the hospitals has the best evidence for preventing suicide. We have studied on firearms from Canada, on pesticides from Asia and Latin America, hotspots and jumping sites from many places in Asia, railways and subways from Europe, medication everywhere in the world, and from the hospitals in some Western countries. And of course, self-poisoning with pesticides is very important in the rural areas of Asia and Latin America. And there are two very successful examples. One from Sri Lanka, showing that in 1980s, 67% of suicide in Sri Lanka were from pesticides. And now we can see the drop up in annual suicide rate in the year 2016. And it is a very cheap preventive initiative because you have the control of access to the pesticides in the village, and the key is stored in safe place. The similar results we have during the shorter period of time in Korea, Republic of Korea. Between 2012, there is a total decrease of suicide, which was very significant. We know also, as I mentioned before, the alcohol use was reduced in many countries during the COVID-19 pandemic. And we know that there is strong association between alcohol use and suicidality, and the policies which reduce through restriction availability of alcohol, increase cost of alcohol, decrease the minimum legal drinking age, and have more strict drunk driving laws, they have lower suicide rates. And the best example is alcohol restriction during perestroika, which means restructuring, and glasnost, which means enlightenment in the former USSR, with President Gorbachev's, who recently died, reforms show the biggest suicide preventive effort and results for men, but also for females, in comparison with suicide rates in other European countries. And the decrease in suicide rates was greatest for men and women in the workforce, 25 to 54 years of age. And also those alcohol restrictions decreased violent deaths to external injuries. It means other violence, fights, and also traffic accidents. and also decrease deaths to accidental alcohol poisonings. We have school-based intervention from the United States Good Behavior Game, Signs of Suicide, and from Europe, Use Aware of Mental Health, which show significant reductions in suicidal behaviors, suicidal thoughts, suicide attempts, and depression in the young people who are exposed to those interventions in comparison with the controls. We need to foster skills in the young, and for example, Youth Aware of Mental Health is fostering positive lifestyle skills like sleep patterns, physical activity, reading books, abstaining from alcohol use, healthy internet and media use, late sexual debut, but also how to deal with stress and crisis and seek help, both within the families, schools, but also in the healthcare sector. Early identification, assessment, and management and follow-up, so-called Mental Health Gap Intervention Guide, which is now updated by the World Health Organization, has also not only modules for mental health disorders, but also for suicide prevention, and it can be used in all countries. Is very easy and a very well-written manual. Crisis helplines. The scientific evaluation show limited evidence, but really, when you look at the qualitative interviews, you can see how helpful crisis helplines are. National suicide prevention lifelines are very important, and they are now in many countries, but also national suicide prevention programs are important. Lastly, I would like to say to be careful with suicide clustering in schools, prisons, hospitals, and indigenous communities, because there is temporal and spatial aggregation of suicides. So if you have a suicide in the hospital ward or in prison or in school, look at the other risk groups you have in that school, and also try to have preventive activities. There is a good WHO guidelines what to do and what not to do, and it has also a lot with the media reporting. It is very important to have responsible media reporting, but also responsible media or professional reporting in schools or in hospitals or in the indigenous communities, which means that we need to be very logical and not to sensationalize or normalize suicide. We need to speak about risk, but also protective factors, and that we have a lot of possibilities, which I showed you before, to treat and prevent suicidal urges. We need to avoid information concerning suicide methods and location, and we need to provide information about health resources. In conclusion, from the mental health care and public health approaches, they should go hand in hand to obtain as much synergy as possible in the treatment and prevention. And I would like to recommend for the researchers my Oxford textbook of suicidology and suicide prevention, second edition in 2021, which has several chapters, several hundred pages on suicide in different contexts, social, political, cultural contexts, in relation to somatic disorders for different groups, and about worldwide networking in suicide prevention. But for those of you who are very busy, and unfortunately most of us are very busy, I recommend an easy-to-read book for all about suicide and unnecessary death, published also by Oxford University Press. Thank you. for listening to my lecture, and I am looking very much forward to see you during next World Psychiatric Congress in September 2023 in Vienna, which is a city connecting Europe westward, eastward, southward, and to the north, with great opportunity within a couple of hours to spend more time in Europe. Thank you once more.